Hi, Dr. Peterson here with RegionsEMS. This is the daily COVID-19 update for Friday, March 27th, 2020. Information presented in this video is current as of Friday, March 27th, but can change from day to day and even hour to hour. Please reference our website, RegionsEMS.com. Click on the COVID-19 link at the top, and you'll be directed to our resource page, which has lots of information available for you, as well as a summary of the information contained in these videos. We will review that page on a daily basis and update the date so you can be confident that the information you're receiving is current. We're going to change up this format a little bit. Instead of reading the same things over and over every day, I'm going to kind of emphasize a specific topic each day, and then those topics will repeat on a weekly basis. So within a week, every daily video should be slightly different, hopefully to keep you engaged and keep some of the points fresh in your mind. First of all, let's talk about our current state. CDC as of today is reporting nearly 70,000 cases in the United States. I have heard numbers on the media higher than that, so I expect that number will go up today. And total deaths have reached 1,000 in the United States. That brings us to the #1 country in the world as far as the number of cases that have been diagnosed. In Minnesota, we have 346 positive cases as of yesterday evening, out of approximately 13,000 tests that have been run, and I can tell you that the number of patients with symptoms are quite a bit higher than that. We just haven't tested everybody. There have been 2 deaths reported and 41 cases requiring hospitalization overall. In Wisconsin, as of yesterday, they are reporting over 700 positive cases out of about 12,000 tested and 8 total deaths. I think we're about 3 to 4 weeks away from where we're really going to see things ramp up. But again, we don't know a lot about this virus, so that could change, and that could happen either a lot sooner or a lot later. It just depends on how things play out. So a couple updates before I get into today's topic. We talk about crisis standards of care, and with that there's 3 phases. There's a conventional phase, which is our normal day-to-day operations that we would be in outside of a pandemic. As we stress our resources, we move into a contingency phase, which is where we start to modify our day-to-day responses. As medical directors, we believe we are in the contingency phase right now. We're not necessarily feeling stretched, but we have started modifying our day-to-day responses. So just something to keep in mind that right now this is not entirely business as usual. That said, it's still important that we provide the appropriate standard of care, treatment and transport for patients that request our services. We are not at a point where our resources are stretched so thin that we are having to modify our responses. That would come in the next phase, which we would call the crisis phase of care. And so we're working on our triggers. Your agency should have their triggers for when your operations move into that crisis phase, and how do we modify our responses, our treatments, our interventions when it gets to that point. So we will keep you updated as far as our recommendations from medical direction. But just know that we are in the contingency phase. That's our opinion, meaning that we are starting to modify some of our response plans in our day-to-day operations. I did post on the website some crisis standards of care references that have been approved by Minnesota EMS medical directors in the metro region that you can read through if you're interested in the strategies and the framework that we use to make some of those decisions. Like I mentioned, we have not yet seen an overwhelming spike in cases in either Minnesota or Wisconsin. The models right now are predicting mid to late April is where we're really going to see the peak. But again, those are models based on very limited data. So we don't know for sure when that's going to hit. We just need to be prepared. And then finally, Regions Hospital specific update. Regions has modified some workflows, just so you're aware. The negative pressure rooms are in Alpha 11 and 12, and Charlie 1 and 2. So it is possible that you may be bringing a critical patient, possibly even a trauma team activation, to one of those 4 rooms instead of E1 or E2 as you might be used to. Also, in order to protect some of the staff, the trauma team activations will be modified. We would ask that when you activate the trauma team with MRCC, you mention the reason for the activation. Not just that the patient looks sick, but specifically, they're hypotensive. We've identified these injuries, low GCS, that kind of thing. That will be helpful for the trauma surgeon because they may be downgrading some of your TTA requests just on the basis of limiting the number of people in the room. So don't be offended by that. Everybody's just trying to do what they feel they need to do to protect their own staff, protect other patients, but just be aware that some of your TTA requests may be modified based on information you provide in the triage from the trauma surgeon. All right, so today's topic, let's talk about protecting yourself. And I'll just reemphasize the points that I think are important for you to keep in mind. So number one, best thing you can do to protect yourself, put a mask on the patient as soon as you encounter them, if there's any suspicion of COVID-19 infection. Also, we need to limit the number of providers involved in patient care. For most situations, you may only need one person involved. Obviously, if there's lifting and moving, then you need to involve more people. But as best we can, let's only suit up one person. Send in a scout, do a scene size up, evaluate the situation, and then decide if more people need to get involved if necessary. Whenever possible, ask the patient to meet you at the front door, or if it's a care facility, ask the staff to bring the patient to the front door so that you don't have to enter that facility with possible infectious individuals inside. That may not be possible in all situations, but whenever you can, if you have access to a callback number or ask dispatch, that would be something very reasonable to consider. Number three, no Nebs in the ambulance. We've harped on this. Nothing that generates aerosol particles. Even in the hospital, we are limiting the use of BiPAP and CPAP for patients with suspected COVID infection. It's just really not worth it. If they're in that much distress, they probably just need to be intubated. So for sure, let's avoid BiPAP or CPAP unless absolutely necessary. And if you absolutely have to give a Neb, do it outside of the ambulance, not in the ambulance, not in the confined space of the back of the ambulance. There are also some inline viral respiratory filters available that we are procuring through RegionsEMS. Your agency may be able to get some on your own, but if you're having trouble finding them, please contact us and we will assist you. These inline filters can be placed in line with a CPAP mask, with a BVM, or placed on the exhaust port of a nebulizer setup so that you're filtering all of the exhaled gases and particles. Let's try to maintain 6 feet of separation whenever we can from the patient. Only get close to them when you have to do a hands-on exam or for a procedure, but whenever we can, let's maintain some social distancing between us and our patients. If you're a first responder, do your initial scene size up through a window, from a doorway, from a distance. If the patient is alert and not having any distress, you can probably just stage for EMS and you don't necessarily need to enter that residence or do a hands-on evaluation. We don't need to repeat things when not absolutely necessary. For the transport agencies, if your patient does require transport but appears stable and is unlikely to decompensate, require any further procedures, or require close monitoring, in Minnesota at least, during the current suspension of EMS regulations, it's okay to transport a patient in the back of the ambulance by themselves. You don't need a provider in the back of the ambulance if the patient is at low risk for deterioration. That would just be another way to protect yourself, limit the time that you're in close contact with the patient. And then finally, also keep in mind that homemade masks, there's been a lot of media, a lot of people that are really trying to help and make homemade masks. Currently, they are not considered PPE. You can sure wear one, that's fine, but don't think that it offers the same protection as a surgical mask or an N95 mask. People are wearing them over an N95 mask to further protect the N95 mask, but the homemade masks are not considered personal protective equipment and should not be assumed to provide any protection against the respiratory viral particles. So that's it for today's topic. Send any questions to RegionsEMS at healthpartners.com. Look at our website, RegionsEMS.com, for our frequently asked questions if you have any concerns. And then finally, I'd just like to end with a daily trivia question, flu related. I'll present the answer on Monday's video, but if you think you know the answer, please email us, RegionsEMS at healthpartners.com. And I'll try to do a shout out on Monday to the smartest among us who may have the answer to this question. So today's trivia question, where does the term quarantine come from? If you think you know the answer, email us at RegionsEMS at healthpartners.com. Otherwise, have a great weekend. Stay safe, stay healthy. That's it. We'll see you next week.